I think because of social media, and I think because there are so many practitioners out there now talking about estrogen, I think that the public is just going to be demanding estrogen and progesterone, right? There's no reason to suffer.
Hi, Skin Friend. Thanks so much for tuning in to this week's episode of The Skin Reel. This week, I'm really excited. This is a first-ry, having an OBGYN on, an obstetrics and gynecologist on to discuss women's health. I am so thrilled to have Dr. Sadaf Lodhi on with me today. She is a board-certified OBGYN with a focus in sexual and menopausal health for women, and she has a private practice in New York. She is also a certified sex counselor and educator. In addition to being an OBGYN, she also is the host of the Muslim Sex Podcast, which helps bring about topics that are maybe taboo and not spoken about as openly to the global audience. And I love that she is doing that. Her mission in life really is to help empower women and to remove mental and physical barriers so that they can find pleasure in their relationships. So I love that. And we're going to be talking about perimenopause and menopause because this is an area of women's health that has been kind of neglected and forgotten about. It's like women, once we can stop having children, we're sort of like put out to pasture and forgotten about. So I love that doctors out there, people like Dr. Sadaf, who are Menopause Society certified, putting amazing information out there to help let women know that the symptoms they're feeling, the things they're struggling with, they are not alone, they're not going crazy, and that there are things that can be done to help. So if you're a woman, no matter what age, hopefully you will live long enough to experience perimenopause and menopause. So you are definitely not going to want to miss this episode. Dr. Sadaf, thank you so much for being here. I'm so excited. You are my first OBGYN on, and I love that we're talking about perimenopause and menopause as a woman in her mid-40s myself. So I really appreciate you taking the time to be here.
Thank you so much for having me on. I'm so excited to be on. I've never been on with a dermatologist. So yes, it's exciting for me. And actually, I lied because I was on with a dermatologist. I was just on with you on my podcast. So
that's right. Yes, we got to have back to back. And anyone is watching the video, Dr. Sadaf has amazing skin. I have seen it in person, and your skin like makes a dermatologist proud. So you can maybe share your secrets later on what you're doing because it's amazing.
Oh, you're so sweet. Thank you so much. And coming from a dermatologist, I am really honored.
I would love to hear in your own words who you are, what you do, and a little bit more about all the cool stuff you're up to.
I am a board certified OBGYN, and I am a Menopause Society certified practitioner, which means basically that I specialize in menopause and that I took an exam. I studied a book and I took an exam to become a Menopause Society certified practitioner. I'm also an ISWISH fellow, which stands for the International Society for the Study of Women's Sexual Health. So they are a group of practitioners that focus on sexual health. So I also am an ISWISH fellow. I did a year-long course with the University of Michigan on sexual counseling and education. So I'm a sexual counselor. And I also did coaching through Rutgers. So I'm a sex coach. So I do all of that. And I also have a podcast. So it's called the Muslim Sex Podcast.
Wow. So I feel like my podcast seems really dull and boring compared to the topics you cover on yours.
No, it is fun. It is fun. Yeah, I love it.
Very cool. Well, so there is a lot of changes that happen in perimenopause and menopause. And I think sometimes women, we don't necessarily know that it's due to that. We just notice the changes. So for instance, as a dermatologist, I get people coming in saying, I'm losing my hair. My hair is thinning. I used to have beautiful thick hair. Now it's thinning. Or, oh my gosh, like I feel like I woke up and my face just melted. Like I'm getting gels. My skin is crepey. And so they'll be noticing these changes and not necessarily knowing that the cause of it. So I feel like we're hearing these words, perimenopause, menopause, a lot more now than ever. But just kind of as an OBGYN, what does this mean and what is it?
Perimenopause is a time around which before you have your last menstrual period. So that's when our hormones are going up and down. And so let's just go over what menopause is. So menopause is the time in which a woman does not have a period for a whole year. And one of the first things to become irregular when she's going through perimenopause is her period. So her period starts to become, sometimes it can become longer, sometimes it can become shorter, sometimes she skips months. All of those things happen because of the fluctuation that you have in the estrogen. So our estrogen basically, our menstrual cycle is a cycle, right? There are times when our estrogen is high, then it's low. And when it's low and our progesterone is low, that's when we have our menstrual cycle. But during perimenopause, our hormones are kind of all over the place. And that's because your body is kind of getting rid of all of the oocytes. So basically of all the eggs, right? They're getting rid of all of the eggs that we have. And when you no longer have eggs to ovulate, that's when we stop bleeding, and that's when we go into menopause. Now, a lot of the common symptoms that women tend to have during perimenopause are hot flashes, night sweats, mood swings. One of the things that we talked about before and on my podcast was brain fog. I think that ends up being really big for a lot of women. And like you said, a lot of times we don't put two and two together. We don't realize that the reason why we have this brain fog is due to the loss of estrogen. And the reason why that is because there are lots of estrogen receptors in our brain, specifically in the hippocampus, the amygdala, and also the hypothalamus. And so when we have a decrease in the estrogen in those parts of the brain, and they have all those estrogen receptors, and when we're not getting that estrogen into the brain, we have what's called, the brain fog. And also we have that mood lability. So we have those mood changes because of the lack of estrogen that we're getting into our amygdala, which is responsible for our feelings and our emotions. And so that's one of the biggest symptoms as well that women get during perimenopause. They also have like joint pain. You can get like all these strange things, definitely hair loss. We know that. I mean, there's estrogen all over the body. And so women will have a lot of these symptoms. Sometimes some of the things that women come to me for, aside from irregular menses, is pain with sex. Women will notice that, they have decreased lubrication during perimenopause. They'll notice that they have decreased libido. They don't really know what's going on. Why are they having decreased libido? So all of those things tend to come up. And what we also know by studies that were done, one of specifically is the SWAN study that was started in 1994, and is a multi-center study that basically followed women through midlife. And what they noted was that based on your ethnicity, really determined how long you experience perimenopausal symptoms for. So like the hot flashes, the night sweats, the mood swings, all of that stuff. And what they noted was that African-American women tended to go through perimenopause for a much longer period of time, specifically 10 years. Caucasian women, about 7 years. Hispanic women, they noted 8.9 years, and Asian women, so we're talking about those from Far East Asia, they noted about 5 years, and they think perhaps that's due to their diet. But it's really important to note that, if you are in this midlife for women and you go to a doctor, and something that I didn't mention is heart palpitations and anxiety and new onset depression. All of those things can happen during perimenopause as well. In fact, I think Oprah mentions that one of her first symptoms was heart palpitations she started having. And all of these things are really important to know. And there's so many symptoms that women can experience. I think they see like over 200 symptoms that a woman can have during perimenopause. And unless you're familiar with the fact that you can have so many symptoms, you go to a primary care doctor and they may just dismiss you because they themselves may not know of all the symptoms that can happen. So it's really important to be informed. And, the mean age for somebody to go through menopause is around 52 here in the US. But if you are, say 42, and, you're having these symptoms, I would go and find a practitioner that can help you to figure out that perhaps you are going through perimenopause and not dismiss you. I think that happens a lot to women. And it's really important for them to know about these symptoms and then to be able to advocate.
I had no idea that perimenopause could extend for that long. So it sounds like for best case scenario, it's 5 years. And worst case, it could even be close to a decade of going through these symptoms. So, I mean, that's crazy. And that's a huge chunk of time. And I could totally see how these symptoms can seem sort of vague and unrelated. And maybe not even dismissed, or maybe then you start going, well, go see this doctor, go see that doctor, go see this person. Then you're just playing the witch doctor all around on who to see, and not really, when really it can be something as simple as estrogen. So what do you do if you're experiencing some of these symptoms and you're found to be in perimenopause? Is there something you can do?
So studies have shown that estrogen and hormone replacement have really, really helped. And actually, so, I know that you and I were talking about this a little bit on the other episode, on the other podcast. So basically, in 2002, we had a study that came out, which was a WHI study that basically was a study, again, that was a randomized placebo trial that was halted early because the NIH at that time felt that there was more harm being done in that study than benefit. And they took women that this study, they were trying to assess whether or not estrogen, and specifically they were testing synthetic estrogen and not bioidentical estrogen, which is the one that we most commonly use now, which is the estradiol. The synthetic hormone, the synthetic estrogen that they were using was a conjugated equine. Basically, it was made from horse urine. And they were using that estrogen, and it was oral estrogen. And on top of that, they were giving estrogen to women that were quite advanced in menopause. So the mean age for somebody that was in menopause in their trial was in their 60s. And we know now that the best time for somebody to go on hormone therapy is actually during perimenopause and early menopause. So typically we say that if you're going to start hormone therapy, it should be started within 10 years of your last menstrual period or before the age of 60. The reason for that is because a lot of the chronic conditions that happen have already happened by the age of 60. So for example, we know that as women go through perimenopause and into menopause, we know that they may develop insulin resistance, that they may develop diabetes, that as they go into menopause, their risk of cardiovascular disease increases, their cholesterol increases. Basically, all of these chronic conditions, their likelihood increases. And so by the time that a woman turns 60, those chronic conditions have already had a long time to kind of take place and really impact a woman's life, right? So if she started perimenopause around at 49 or 48 or whatever, and then you start giving her hormone therapy at 63, it's probably not going to be as helpful as had you started when she was in perimenopause and menopause. And really, there is an author, his name is Dr. Avram Bluming. He's an oncologist, and he wrote a book called Estrogen Matters. And he actually believes that estrogen is preventative. And I would think that I'm kind of on the same thought process as he is, that really estrogen is preventative. It prevents you from having osteoporosis. It helps mitigate your vasomotor symptoms, your hot flashes, your night sweats. It's going to prevent that genitourinary syndrome of menopause that we're going to talk about a little bit later. It's going to prevent you from having colon cancer. It's going to prevent the heart disease. And there's a study that just came out, I believe it was just released in the Diabetes Journal. I'm sure you probably saw that as well, that women that in perimenopause that go on estrogen, they have a reduced risk of diabetes by 30%. Of developing diabetes into menopause. So really, for me, I think that estrogen really is preventative. And, as you mentioned, hair loss, right? Estrogen would also help with that. So I don't know. I mean, for me, it's almost kind of like the miracle drug. Now, I don't want to say that everyone should just run out and get estrogen. Obviously, you have to go see your provider, and you have to make sure that you are a good candidate for hormone therapy. Definitely, we know that oral estrogen has a few more side effects and can cause some problems, like it can increase your cholesterol, it can make you at risk for blood clots. But the one that we give now, right, is the transdermal estrogen, which is the estradiol patch. And we know that that is really safe in most women. And that patch you put on twice a week. And really, it has great systemic coverage, and it will help prevent all of these things that we are talking about with the diabetes and with the genitourinary syndrome and with the hot flashes and night sweats. In fact, estrogen is FDA approved for vasomotor symptoms, for hot flashes and night sweats. And of course, it is protective for osteoporosis. So many reasons to go on estrogen, and really it's important to discuss it with your own doctor to make sure that you are a candidate for estrogen.
Yeah, and maybe not to wait until symptoms are really bad or you're well into your 50s or 60s to start it. Maybe really having this conversation early and sooner, it sounds like, is the way to go. What are some of the holdups then that people have if we now know that the WHI study has now retracted their claims? Like, what's the holdup with people being put on it?
I think one of the biggest problems is that practitioners are not up to date as to who is a candidate, who is not a candidate. And really, to be honest, most people are candidates for hormone therapy. And like I said, the patch is really, really good. And there's very few contraindications to the patch, So we're not talking about the oral, we're talking about the patch. And I think it's just practitioners do not have the information. I think that they're stuck in what we learned about 20 years ago, which was that take everyone off of hormones is not safe. And now we know that it is safe, but, people are not keeping up with their reading, or they're not, up to date. They don't have friends that prescribe hormones, and so they don't feel comfortable with it. And I think that a lot of times is the knowledge gap. I think it's that practitioners, they themselves don't feel comfortable because they don't have the knowledge and they haven't done the research on the knowledge to gain the knowledge. I think that patients really should go on, menopause.org to find practitioners that are comfortable prescribing hormones so that they can get hormones. And like you said, the best time to really go on hormones is really in perimenopause.
I'm all about prevention too, like with so many issues that happen with our skin. If we could just prevent them or start early and recognize, it makes such a difference. So I love that. I feel very blessed that I'm a woman in this 2024, living through my 40s and 50s and 60s, because I feel from like my mom's generation where they were given nothing and they were just told, this is nature, it's natural, deal with it, which I think as women, we hear a lot. Oh, it's just a miscarriage. It's just cramping. It's just whatever, right? Like deal with it. And now we're realizing, well, actually, it's more than just uncomfortable. It's actually life-threatening when your body is depleted of estrogen. The other thing, as we know, we're all living so much longer. So instead of dying at 47, which was the average lifespan in 1900, right, people could easily live. I have a grandmother who's 101, and we're just going to see people get living longer and longer. And I know I want to live as healthy as I can for as long as possible. I don't want to be breaking my bones. And we already are hearing women say, enough of this. Like, we deserve to have research and treatments for our symptoms and the things we're going through. And that's what I love, that OBGYNs like you are really leading the way with that.
I think with social media, there are so many people on there, some of both that you and I follow, I'm sure. There are lots of physicians talking about perimenopause, menopause, and how there are therapies out there. And remember that if you are going through like vasomotor symptoms, like the hot flashes, the night sweats, the mood swings, and you decide that you don't want to go on estrogen, there are other therapies available. There are other medications out there as well that are not hormones. But, if we're, as physicians, we're always trying to find the root cause of a problem. And if we know that the root cause of the problem is estrogen depletion, then really it means that we should go back on estrogen and get that so that we aren't going and having those hot flashes and night sweats. So I think because of social media, and I think because there are so many practitioners out there now talking about estrogen, I think that the public is just going to be demanding estrogen and progesterone, right? There's no reason to suffer, especially when we have the resources here to mitigate those problems when we reach older age. And, if there's ways to mitigate having osteoporosis, having, heart disease, or going and, becoming diabetic when you were never diabetic and you're so healthy and all of a sudden now you're pre-diabetic, if there's ways to avoid all of those things, why not use it, right? We have those resources.
That's what I say. But how would you, and I'm sure you get this, someone challenge you by saying, this is nature, this is natural. Let it be. You don't need to treat something that's natural. What's your response to that?
Yeah, actually, I do have a friend that said that to me. She said, well, I'm just going to let nature take its course and this is what's meant to be and things like that. But I would say that if you have a treatment for something that can be cured, why not cure it? Like I know somebody that has cancer, right? And I know that there's really no comparison between cancer and, hormone depletion. But, the woman said to me, she was like, well, I have a recurrence. She was in remission and now she has a recurrence of her cancer and she has Mets. And she's like, but there's therapies for it. And she's like, oh, I'm just going to let nature take its course. Maybe this is what's meant to be. Maybe I just won't get treatment. And I said, why? That makes no sense. Like you have treatments available. Like, it's not your time to go. There's medications that are available to treat what you have. So I would just go ahead and get treated. The same thought is why are you going to go ahead and get diabetes or, heart disease or genital urinary syndrome of menopause or all of that stuff when we have therapies for it? You don't need to live like that. I mean, sure, if you want to have recurrent UTIs and have pain with sex and get urosepsis when you're older, I mean, that's your decision and, that's what you want to be. But I know what I want to be like when I'm 90 years old, right? And how is that? I know I want to be strong. I know I don't want to be in a nursing home. I want to be able to do things for myself. What's going to help me to get there? And I know for me, at least that's estrogen. And that's, estrogen and progesterone and lifting. And we know lifting heavy weights and eating protein and getting outside and getting enough sleep. Those are really like the 4 core things that you need to be healthy. And so I think that that's just really important.
I totally get it. And I'm on the same page with you. And I'll tell people too, well, having an infection is nature, right? Getting bacteria in a wound or whatever, that's nature. And if you break your leg, like, are you not going to fix that, right? Does anyone give men a hard time about taking Viagra? Does anyone tell them, hey, buddy, that's just nature. That's just the way it is, right? So I don't know why we do this to women. Like, no, you just need to, toughen up. And that's just the way it is. So we have a different approach to women than to men. Like no one ever says, you don't need Viagra. This is nature. It's just not your time anymore. So
I know, right? Exactly. What's so interesting is that I feel that, here, especially in Western society, I feel like we have a really different approach to like menopause. I think people are really afraid of the word. I feel like when I talk to my friends that are perimenopausal, they're like, oh, no, I'm still getting regular periods. That's not me, like
that's them, not me.
Yeah, we equate like perimenopause, menopause with aging, and aging is seen as so bad. Like you don't want to age, right? It's always about like anti-aging. So, and I'm not against that, right? Like I think it's, to be as healthy as you can forever. But I mean, it's honestly, there's no other choice. I mean, everyone has to age.
Or you don't, and that's not a great alternative either.
That's what I mean. Like, what's the alternative? You die.
I'm with you. I had a patient who is about my age or maybe a little bit older, but I said, are you having any symptoms or do you think maybe you could be going through perimenopause? And just to your point, like she was taken aback, like, oh, no. Like that's for old people. That is not me. So I think the first step, right, is just talking about it, normalizing it, not being embarrassed or afraid or ashamed that these things are happening to you. And actually, I find it almost a relief to say, oh, well, maybe I'm not just depressed or I don't necessarily need to go on an SSRI. Maybe I just need to go see my OBGYN and get on estrogen. So now I kind of seek out this information because it interests me and I want to be as healthy as I can for as long as possible. But so many people don't even know about any of this. And so again, why it's so important to be having this discussion.
I'm glad you brought up, kind of like this multi-pharmacy, right? So what happens is that women are having all these symptoms in perimenopause. Nobody's connecting the dots. Nobody understands that it's the decrease in estrogen that's causing this mood lability, that, why she has this new onset anxiety, why her anxiety is like through the roof, or why she's developed depression and she was never depressed before, and what's wrong with her, whatever, is that nobody realizes she's in perimenopause and, perhaps some estrogen could help her. Instead, they start treating all of these symptoms instead of going to the root cause. So, now she's on an SSRI, but that SSRI, that, that Prozac or that Zoloft is actually now affecting her libido. And so now she's going to go on something for libido, but it's really the medication that caused that. You know what I'm saying? So all of a sudden now people end up taking all these medications when really what they could have started with is estrogen and progesterone if she still has a uterus, and, and maybe not have to go on so many other medications. So it's really the polypharmacy that ends up happening in perimenopause and menopause, going on the statin, going on metformin for diabetes, going on, for high cholesterol, blah, blah.
Yeah. Well, let's sort of segue to topical estrogen, because even in the derm world now, I'm starting to hear about this. One of my favorite compounding pharmacies, Skin Medicinals, now has an estrogen cream. I'm starting to hear about people using it, people asking about it. So can you shed some light onto it? I know you've got experience using it topically in the vulva region. So what's going on with the skin down there?
When we look at the skin in the vagina and in the vulva, what we notice is that when there is decreased estrogen, the skin, the cells, they change. And basically, what we notice is that the postmenopausal woman's vaginal tissue change, and it's characterized by a decrease in what we call superficial epithelial cells. So basically, cells at the surface of the vagina and of the vulva. And what happens is that epithelium, so those tissue, that tissue that was up on top of the vagina, starts to thin out. And we know that in the vagina, there are ridges, and that those ridges also tend to go away when those cells change. It has less blood flow and it becomes dry. And without all of that glycogen-rich tissue that we had before, there is a decrease in the amount of lactobacilli in our vagina, which also then can lead to a higher pH. So basically, it can make women that are postmenopausal more at risk of having infections or a higher risk of having bacterial vaginosis. And this is all because that tissue changes. And it also leads to a higher risk of bladder infections and basically that recurrent UTIs. And so what can happen is, especially say, for example, if a postmenopausal woman is in a nursing home, right, and then she has the increased UTIs, what can happen is that bladder infection can actually turn into sepsis. And if nobody detects it or nobody even knows what's going on, it can actually lead to death. And so that's why we say that really when women are on estrogen, vaginal estrogen specifically, that they really stay on it for the rest of their lives, because it's really going to prevent them from having recurrent infections, recurrent bladder infections, and could quite literally save their lives. Also, what we know is that when women go on this vaginal estrogen, and what I do is I prescribe vaginal estrogen cream for women, because even though it can get a little bit messy, I tell them to use it at night. And what I do is I tell them to put a little bit of the cream up until like the first line of their finger, and put that vaginal cream inside of the vagina and kind of rub it in, and then also on the vulva to help maintain that tissue, to prevent that thinning out of that tissue and the decreased blood supply. We know that vaginal estrogen can actually restore the pH of the vagina and make it within normal limits so that it returns to the normal microbiome of what that vagina was. So it'll favor the growth of lactobacillus, and it will discourage the colonization of bacteria or things that can contribute to bladder infections. Also, we know that protection against UTIs with the use of estrogen really helps. We know that it works. There have been studies that have shown this, and that even if you are on oral estrogen or on the patch for estrogen, it does not help the tissue inside of the vagina and the vulva. So we really need that cream. You really have to. So what I do is when I prescribe somebody estrogen, I'm giving them the estrogen patch, which is the estradiol patch, and the progesterone, especially if they have a uterus. Sometimes even if they don't have a uterus for say they had a hysterectomy or something like that, that progesterone can also help with sleep. So even women that don't have a uterus may benefit from progesterone. But definitely if you have a uterus, you absolutely have to go on progesterone as well. So I will do the estrogen patch, I'll do the progesterone orally, and then I'll also do the estrogen cream, because the estrogen cream will really help out with that tissue. And we know that it's going to stimulate the growth of those vaginal epithelial cells. It's also going to thicken that layer, that tissue, which was starting to thin out, is going to become thicker. There's going to be increased blood flow. The tissue is going to be more elastic. And so, sometimes postmenopausal women, that tissue becomes so thin that when they start to have intercourse, aside from it being painful, it can actually tear. So, it's going to allow that tissue to be more elastic, and definitely lubrication is going to be better. And so by improving that vaginal tissue, it's going to help to get rid of that vaginal dryness, that pain with sex. It's going to return those ridges that were inside of the vagina. It's going to help those to stay nice and plump, and it's going to allow for that vaginal tissue to expand and be elastic. And we know, like I said, it's going to return that blood flow. So all of those things are going to be super, super important. We know that vaginal estrogen does not increase the risk of blood clots, so it's super safe. And even if you decide you don't want to take estrogen for the rest of your body, like you don't want to take it for the vasomotor symptoms or the hot flash and night sweats, make sure that you at least use it for the vagina and the vulva, because it's really going to help and prevent that pain with sex. But even if you're not sexually active, it's going to prevent those recurrent UTIs. It's going to maintain that vulva and that vaginal health.
And studies show it's not systemically absorbed, right, when you use it topically?
Absolutely, yes. It does not go all over the body. It stays in there, just in the vagina. It's local, so it's only going to affect that local tissue. It's not going to travel throughout the body.
Interesting. I would have thought by taking either the estrogen pill or using the patch that you would get those benefits in the vulvar skin, but you're saying no?
No. I mean, if you do, it's minimal. You really need that vaginal estradiol cream. That's going to help with that tissue the most. And like I said, I like the cream, but there's different ways. There's tablets. There's a ring. There is something that is a capsule that you can put inside that's not as messy. The only reason I like the cream is because you can take a little bit of the cream, put it on the inside and also on the outside.
And you can even put it around your eyes, So people are using the estrogen cream now, the estradiol cream on their skin, and dermatologists are prescribing it. And studies have shown that it can be helpful. Again, it's safe. It's not systemically absorbed. And so if there are areas that you notice some aging, you can put a little around your eyes, put it on your neck, put it on the tops of your hands. And I think we'll see more of this in the future. And I'd like to see more studies showing benefit. But certainly if you've got some and you're already using it, you can also dab it on your regular skin, because our regular skin has those epithelial cells as well that start to flatten out and could use a little boost.
Wow, I had no idea. So that's great. Even another reason to use vaginal estrogen, right?
Use like a clean hand or Q-tip or whatever, I really think, I'm already seeing patients asking about it, some of my friends asking about it, and now I know where I can prescribe it easily. So I do think this is something we'll be seeing more of. It seems really safe. And we know that our skin has estrogen receptors and collagen, and it all reliant on estrogen, because we see the effects when we don't have it. So very important. And yeah, I love how you mentioned estradiol cream is not just for increasing pleasure with sex and dryness. Like it helps prevent these UTIs, these infections that you can get. And I'm sure you remember, right, when we were interns and we're in the hospital, and patients, if they would sundown at night or have increased confusion and all that, the first thing we're worried about, right, is like, oh, do they have a UTI? Let's get a urine culture, because it's such a problem in elderly patients. So I love that. That seems really simple and easy, and I'm all about cream. So
yeah, and especially for elderly patients and those that don't have as much manual dexterity, that they may not be able to use their hands as well. We do have the estrogen ring that you can put in for 3 months at a time. And so they can go in, or, their healthcare provider or, whoever can put it inside their vagina. And then after 3 months, take it out and put another one in, so that they do have the benefit of the vaginal estrogen and they don't have to worry about putting a cream in and out all the time.
Now, you had mentioned earlier the importance of taking estrogen with progesterone if you have a uterus. Why is that? What happens if you just take estrogen?
When somebody takes estrogen, what estrogen does, it promotes the growth of the lining of the tissue within the uterus, right? So that tissue will grow and grow and grow. And if we have unopposed estrogen, it can lead to uterine cancer. And so what happens is, to prevent that from happening, where the overgrowth of the lining of the tissue of the uterus, what we have to do is we have to give progesterone, and the progesterone, it decreases the lining. And so that's why we always, for a woman that has a uterus, we always have to give both. We give estrogen, but then we also give progesterone, because you don't want to create another problem. So you want to prevent the overgrowth of that tissue, the lining of the uterus. That's why you use progesterone as protective. And like I said, it also does help with sleep. And so even if a woman does not have a uterus, sometimes she'll, ask for something for sleep, and then we can also give progesterone for that.
What are some of your other treatment options for people coming in with symptoms that are commonly seen in perimenopause and menopause? Like, beyond estrogen and progesterone? Are there other things you recommend for a woman going through this period in their life, supplements perhaps, or other things that you think could be helpful?
So I don't do too much with supplements, although there are definitely lots of practitioners that you find on social media and Instagram that also prescribe supplements. Some of them will prescribe turmeric, some will prescribe also magnesium and zinc, and others will also prescribe some collagen to help with all the collagen that we lose. Turmeric we know is an anti-inflammatory, and so that's to cut down on the inflammation as we get older. Zinc and magnesium are used a lot of times. Magnesium I know for like intracellular things that happen in the body and in the cells, but I don't usually recommend those just because I don't dose them as much, but I know that there are practitioners that will do supplements of zinc and magnesium and turmeric and collagen just to promote all of the functions.
I'm a big fan of vitamin D, especially, because I do sun protect, and I know people will say, oh, just go spend 15, 20 minutes outdoors and then get your vitamin D. But the problem is, as we age, we are unable to synthesize vitamin D in our skin. So you're getting the damage from the UV radiation. You're not getting the vitamin D synthesis. And then if you have darker skin, you already have a harder time synthesizing it in the skin. And so I would say a good thing if you're getting your blood drawn is get your vitamin D levels checked and see what it is. And what we're finding is that for a lot of people, it's suboptimal, and supplementing with vitamin D can be really helpful. It helps with inflammation, helps with our immune function, so many different things, hair, like a lot of stuff in our bodies, bones, all of that good stuff. So that is one I do recommend. Usually get it checked first, see where your levels are, because sometimes people need significantly more than what's just in your multivitamin.
Yeah, you're right. And actually, I think it's like they recommend the vitamin D3, the
cholecalciferol. And a lot of people recommend pairing that with a K2. So just to help with absorption. So I know I finally got my vitamin D levels checked, but I had been supplementing pretty high, and I wasn't as high as I thought I would be, but I was within the normal range. So I think people would probably be surprised. And we're learning, just like we are about the benefits of estrogen, that vitamin D is so important in our bodies as well. And a lot of us are deficient. But again, I just will caveat, don't think just run outside and get sun is going to do it, because for a lot of people, especially as we get older, you can't synthesize it in your skin.
Yeah, you're absolutely right. I mean, definitely. I feel like I did read that about the vitamin D and how women tend to be very low in vitamin D, and that it can lead to depression. It can lead to, just mood lability as well. So it's really important to get your vitamin D, and you compare that with calcium. And usually calcium, you need about 1,200 milligrams. You don't actually need more than that. I used to tell women 1,500, but reading now, it says just about 1,200 is about enough. I think vitamin D, they recommend like 400 international units.
Actually, thousands. So I think most multivitamins will have about 1,000 international units in it, but studies show that actually taking 4,000, maybe even 5,000 a day could be helpful. And then there's also a mega version of it. I think it's like 50,000 that people take once a week if you really are deficient. So it's a lot more than you realize, and your daily multivitamin may not have enough in it. So that's one thing that I'm not a big supplement person either, but I finally had a bone fracture last fall and it was slow to heal. And I was like, all right, I better start supplementing with some vitamin D and calcium.
That's a very good point. Absolutely. You absolutely need that, as well as, of course, estrogen will help prevent osteoporosis, but you're absolutely right. You do need the calcium and the vitamin D3 to help with your bones. And especially because we start to lose bone mass, right? Bone mass was even into as early as into our 30s.
Yeah, I also got a DEXA scan. This was my year of...
Wow, DEXA.
Yeah, but I was good. But yeah, I feel like I'm at risk for osteoporosis for sure. So I have to be careful. And yeah, weight training, right? That can help mitigate that as well. Yeah. So, I mean, there's lots of things that can be done, but it's like the root cause, right, of so many of these symptoms that women go through in their 40s, 50s, 60s, and beyond is from simply precipitous drop off of estrogen that we have. And correct me if I'm wrong, I think I read somewhere that like a 70-year-old man and woman, the man's going to have more estrogen in his body than the woman. I don't know. know if that's true or not, or they're both really low.
I don't know that study or that saying. I'm not sure about that. So I don't want to say something that's incorrect, but definitely, I mean, we know that if we don't supplement with estrogen, I mean, really plummets very quickly and really goes down to zero. So, really important for us to supplement so that we can help all of our systems throughout our body and we maintain that health throughout as we age. And I think, like what you were saying, you really do spend, they're saying really like a third of our lives in menopause, and some maybe even longer than that, right?
Right. You go through menopause in your 30s, early 40s, and you live to 90s, right? That's more than half your life in this period. So we're primed to see a lot of growth in this area and interest. And I think it's exciting, and definitely the time is right. So I love that we're even having this conversation. Dr. Sadaf, I'd love for you to give us like your top 3 takeaways for someone, a woman experiencing some of these symptoms, not sure what's going on. What should she do?
The first thing that I would say is definitely, maybe even keep a journal of your symptoms and the things that are going on that that just kind of feel off, that you're not really sure about, things that have changed for you. Maybe you're snapping at your, family members and you never did that before and you just don't understand. Maybe you're crying all the time and maybe, things are changing. Maybe you're lying in bed and you're having palpitations and you're like, what the heck? I think that was one of my first symptoms as well. I went to my doctor and he asked if I wanted to do a 24-hour Holter. I did a stress test and all of that because I was having palpitation. I just couldn't understand what was going on. Of course, you want to make sure you get your thyroid checked as well and make sure there's nothing off with that. If you're having irregular menses, all of those things, you really should go. First, I would write down all of these things going on. Secondly, I would go to my primary care doctor and just ask, if perimenopause could be the cause of all of these things changing, right? Because all of these things are kind of happening at the same time. And if you don't get the answers that you feel are appropriate, or if you feel like you're being dismissed, or, you really don't know, or the doctor doesn't know, then maybe go to someone that's a menopause practitioner that may know, that could help you. Also, we know that, we don't really check hormone levels. And I know that sometimes a lot of women will come to the office and ask for, their estrogen to be checked or their, progesterone or whatever. And it's really important to know that we don't check hormone levels because those hormones are in flux. Sometimes they could be high and within normal range. Sometimes they could be low and, really not give us the full picture. What gives us the full picture are your clinical symptoms that are going on. So I think that that's really important to know and realize. Also, something that's important is that if you are in menopause, that postmenopausal bleeding, so bleeding after you're in menopause, which means that you've had no bleeding for a whole year. And if you start to experience bleeding after that, make sure you always, always, always get that checked out because it could be a sign of uterine cancer and we never want to miss that. So make sure that if you ever have any postmenopausal bleeding that you go and get that checked out. Sometimes I've had women come to me in the office and say that, oh yeah, I stopped bleeding. And then like 3 years later, I started bleeding again. And then it went away and then it came back. And then I asked them if they ever had that checked out. They're like, no, I just thought that was normal. I didn't really know what was going on, whatever. So, I just want your listeners to know that that is never normal to, once you stop having periods, you should just stop. You shouldn't have them back again. So to make sure you always get those checked out.
Great tips and pearls, and can really be life-saving. So Dr. Sadaf, this has been a lot of fun. I've learned a ton, and I know the listeners have as well. Where can people find you and follow you if they want to come see you or just follow all the great information on your podcast or social media?
I am on Instagram and TikTok at Dr. Sadaf OBGYN. I also am on YouTube as well as Dr. Sadaf Intimacy Coach. I also have a podcast called the Muslim Sex Podcast. You can go to my website at www.femvhealth.com. And I've opened up a practice in New York, in Westchester County, New York. So you can look me up there and come and see us. You can schedule an appointment online. And I think that's it.
Wonderful. Well, I will have all of that in the show notes so people can easily find it and click on it and follow you. And I really appreciate your time. Thanks for all the great work you're doing out there for women who are my age, younger, beyond. I love it. And keep doing your great work.
Well, thank you so much for having me on. I really appreciate the opportunity. Thanks so much.
All right. We'll see you next week.